Hello, guys and girls. The program you are about to hear will be both fun and educational, but it is not a substitute for medical advice. Although we are doctors, we are not your doctors.
Uh-huh. What?
Now that it's December, I just hope you all remember to cover up and stay inside. Because prognostications say low rates of vaccination mean a tripledemic URI. Virus in the sky, virus in my eye, passing droplets through the air. If you're feeling like you need a dose pack starting with a Z, we're gonna teach you to beware. You're sneezing, cover up maybe, avoid flu, get vaccinating, RSVs, debilitating. So wash your damn hands and not chew. Red eyes, can't taste and can't rise, turning blue all night. That's COVID-19. No ventilating, I chew, nose drip, coughing, a kid, but you cool all night. That is RSV. Feel suffocating.
Yay!
Oh, wait. Fever, headache, and fatigue, especially in the elderly, is suggestive of flu or SARS. Don't forget pneumococcus as your body starts a ruckus. Grammy decrease just by getting those shots. Droplets in the sky, droplets in our eyes, spreading disease near and far. A simple bit of masking drops your risk of ever hacking up a lung or other body parts. You asked us, so we're advising. Trust us, boo. We sacrificing. Don't end up hospitalizing. Go get your vaccines. And welcome to 2023 Travel Medicine, our very first cold open, because it's cold and flu season.
Hey!
As always, I'm your friendly neighborhood internal medicine doc, Dr. J.
Hi, guys. This is a very surprised and delighted Dr. Santhosh, pediatric infectious disease doc, researcher, and I bow down to your parody skills, Dr. Josh.
Guess who's learned to use more parts of his editing software?
That was so good. Oh my God. That's so good. I love it.
For those of you interested, that will be available individually and separate from this episode on our other feed and possibly YouTube, because while I am learning editing, I am still not great at social media. So everything just goes up everywhere,
Yeah.
all over the place, spreading far and wide like those droplets.
Yeah, absolutely. That's important for sure. Yeah.
But we are going to start having a few more of the, we'll call them formal musical parodies as I try and learn how to TikTok. Doc talk?
TikTok.
Ah.
Although I don't know if that doesn't sound quite like it oughta, I guess. I don't know quite how to phrase it, but yeah.
Well, let's get into it. I know it's not a new season, just a new year, but we have a lot of fun stuff planned for this year. I have used our break to good effect, writing,
Yeah.
outlining, planning, while Santosh has been jaunting off having fun around the world.
And usually it is there is a little bit of role reversal here. Oftentimes, for those of you who are new in here, yeah, Dr. Josh has a beautiful travel itinerary throughout the year and wonderful friends to share it with, etc. And I do love traveling, I do, but I am quite settled with a family, and we it's just tougher for me to be able to jaunt away. But yeah, I just came back from India, Josh, and for the first time ever, I think I was a tourist in my old country of my origin. So not only just looking at my home state and city and everything of Bangalore, but actually traveling about a little bit and seeing the state of Karnataka and enjoying. It was a fun time.
So you picked up all the info about your state, the Bangalore, as it were?
So the state is Karnataka. So yes, Karnataka. I got to go around, and yes, I have pictures to share with you soon. I got to visit my mom and dad's medical school where they fell in love over a corpse. Uh,
As one does.
yeah,
I
yes,
believe that's how our relationship started as well.
absolutely. Yes, they shared a cadaver for anatomy dissection, and that's how they met and fell in love. And so, yeah, I got to
Who
see.
do you have to kill to get a date around here?
I got to fall. I got to see their beautiful, the all the facilities, the anatomy lab, and I'll show you the pictures, Josh. They actually have a beautiful museum with preserved specimens. It's really just it's a fantastic facility that they have there for education. Um, and yeah, I'm excited to talk about it if we want to do like a just the tip, because Bangalore Medical College, being a state facility, is open to the public. It's with guidance and stuff, people are allowed to go and visit, because at least for the people of India, it's their tax dollars that's paying for that facility. So
Probably not the cadaver lab. That'd be tough to get a
no.
foot in the door.
Yes, yes, that's correct. But they do have beautiful libraries and museums, and you can see where all of our wonderful medical students study, and the knowledge that they gather, etc. It's really
Please do
wonderful.
not feed the gunners. Just
No,
observe them through the windows.
that's that's true. That's true. Yeah.
Don't tap on the glass. Makes the surgical students very irritated.
Yes, that is true.
So, I figured in addition to our musical, we should go back to, well, not go back. I figured we should return to one of our recurring segments to start the new year, bring everyone in fresh, new,
Okay.
and
Yeah.
topical.
Uh-huh. Uh-huh.
And I know you're probably a little bit jet lagged, so I wanted to do something to help wake you up and get over that.
Oh yeah, absolutely. So, so no sleeping sickness, for instance.
Right,
That would be, I
right.
think, yeah.
And in the spirit of making you as awake as possible, Santosh, listening
Mhm.
audience, it's time for another Around the World in 80 Plagues.
Oh man, I absolutely love it. And now with new year, new headphones, I was able to very quickly soften so that oh damn it. Okay, never mind. So same as 2022, I guess.
That'll learn you. That'll learn you
Yeah,
real good.
nah, absolutely.
So, this week, the plague we're tackling is one that's getting a lot more airtime lately. Part of our tripledemic URI, which is, of course, RSV, not P. No RSVP. We don't want anyone to come back with this. Just
Sure,
RSV,
sure.
respiratory syncytial
Sinks,
virus.
yeah. It does depend on how you like to pronounce it, and it differs on what side of the pond you're on, like where you learned English, etc. But yeah, over here in the United States, more often than not, you'll hear the term syncytial. So, meaning syncytia are what happens when individual cells kind of merge together. And in this case, it's due to the insult of the virus itself, which we'll be talking about, and partially a defense mechanism and partially a very kind of cruel trick that the virus plays on the cells so that it can propagate much, much more easily.
And all this time I've been calling it syncytial, I've been missing out on perfect in sync opportunities. Like
Yeah.
I could have opened up this episode with a cold open of it's gonna be RSV. Well,
Yeah.
damn.
Yeah, that's fair.
Ah well. Let's take it back to the old school because I'm an old fool who's so cool and
Sure,
talk a
sure.
little history.
Yeah, okay.
RSV, pretty recent virus in terms of discovery as they go. First discovered in 1956
Uh-huh.
and has since been recognized as one of the most common causes of childhood illness. So, as a pediatric ID doc, this is super in your wheelhouse.
Yes, and I will say even more generally, pediatricians as well. This is one of the most commonly encountered viruses that a general pediatrician has to deal with. If you're a hospital physician, you're dealing with the more severe aspects of it. But if you're an outpatient pediatrician, you will see many, many cases of this particular virus acting as one of the most common causes of the common cold or just a mild to moderate upper respiratory tract infection. So very, very common, and very common especially in this respiratory viral season, in this you know flu season.
However, although this is one of the most common causes of childhood illness, it was not originally discovered in humans.
Yeah, that's true. That's absolutely true. I should say not originally recognized. So it was probably around for a very long time, well recognized virus, but it, yeah, the original organisms, the original hosts that it was described in was not human, although it was close.
In fact, I'll give you a hint. The original name before we renamed it to RSV was
Uh,
CCA or chimpanzee coryza agent.
coryza.
Just trying to get a coryza out of me, aren't you?
Yeah,
So,
I am.
and that's of course means chimpanzee coughing disease. Uh,
Yeah. Well, coryza, so we talk about, when we have measles, right? Cough, coryza, conjunctivitis. Coryza is the fancy term, Josh, for, the snottiness and congestion and runny nose and everything that kind of combines in your traditional upper respiratory viral infection to give you that cold like look.
so, a group of 20, and I love how this is in quotes in the paper by Morris et al. A
Sure.
group of 20 quote unquote normal chimpanzees at the Walter Reed Army Institute of Research, which of course makes me think of a bunch of monkeys in lab coats.
They were test subjects, yes.
Right, like grad students.
Yeah, sure, sure. I would say the difference being they're there against their will, but a
Hey,
lot of
hey, the grad students knew what they were getting into,
yeah,
Santosh.
yeah. There's quite a few cynical grad students out there who'd be like, "Yep, just like."
So, curious George indeed. But
Yeah.
a respiratory illness characterized by coughing, sneezing, purulent nasal discharge in a group of 20 chimpanzees at the Walter Reed Army Institute.
Hmm.
Uh, that this, this actually is really interesting when you start looking into the study. So, first described it by Morris et al. In 55, and then Chinook in 1956 wrote on the association of a new kind of myxovirus with an infantile croup or cough that produced a sponge like change in monkey tissue cultures.
Yes. Uh-huh. And by the way, myxovirus is not mixed up virus. MYX in this case, which is a not a genera, but it's a family of viruses. And there are others which are close to it, like orthomyxoviruses and paramyxoviruses.
So that's a separate study with human children, not chimpanzees. But there's a reason that I'm bringing both of these up
Hmm.
because They noted that when grown in these monkey cultures, the it caused this sponge-like cytopathogenic change. The
Hmm.
infants from who the agents were isolated, as well as three additional patients, developed significant increases in complement fixing, hemagglutinin, basically a lot of signs of infections during their recovery period. Let's gloss over that for a moment, Santosh. Try and hold
Okay.
yourself in check.
Sure, sure.
And and in 1957, a year later, you see two isolations of a similar agent from infants who had some pretty severe lower respiratory infections, like a bronchopneumonia, as well as a bunch of additional children from whom they couldn't isolate the virus. This is really starting to show how infectious the agent was. And these two human viruses studied by Chinook and Finberg that we're talking about were indistinguishable, completely similar looking to an agent associated with an outbreak of coryza in chimpanzees, our CCA virus.
Right. Yeah, yeah. So now all of a sudden you're seeing, everything that looks just like the chimpanzee coryza virus, but it's in humans, and very wisely. And Josh, we've actually gone through the same kind of renaming process very recently for now what's called mpox, right? Or monkeypox. So you had all this going on, and they said, you know what? If we're diagnosing this in human children, probably we shouldn't be calling this a chimpanzee virus. That might be a bad idea. So yeah, they named it based off of the pathology, what you saw under the microscope, and you had to prove it. You actually had to go through using sera, so that's the antibodies, to show that which antibodies neutralize what, and you had to really show in that day and age when you didn't have good genetic testing and all that kind of a thing, that hey, these two are actually one and the same. The antibodies against one neutralize the other, but they don't neutralize other viruses, etc. So it was kind of a long and arduous process that they had to go through. But yes, they eventually showed these are one and the same. And let's call it RSV, respiratory syncytial virus.
Back to our 1950s lab, a
Okay.
person working with the infected chimpanzees subsequently, naturally, experienced a respiratory infection. And even though they couldn't isolate the virus from the person, they did note a rise in antibody for the CCA virus. The chimp virus was observed during that person's recovery by looking at sera. So
Yeah.
then, rather than thinking, oh, this is transmitted from monkeys to humans, they mused that there was a suggestion that CCA was actually a virus of human origin that produced illness when introduced into. So it actually went the other way. We gave it to the monkeys.
Yeah, that's that's true. Yeah, yeah. And this wasn't a case where we think about with SARS, where you have mutation and recombination that's going to help it jump across species in terms of hosts. This is just it's general enough as a virus mechanistically that it can go ahead and invade human tissue or chimpanzee lung tissue with equal vim and vigor, so to speak.
And when they tested in the monkeys, they took they took this population, they gave it to a couple chimps, reintroduced them into the population, and then 100% of the chimps got it. So they're like, oh, this actually spreads quite quickly. Uh,
Yeah,
Now, the last paper I'm gonna kind of bring up before we start talking a little bit more about some of the additional symptoms and treatment history is a
yeah.
fun one, just in terms of statistics, which you all know I absolutely love. So I'm going to gloss over the numbers and just get to the gist of it.
Okay.
They in Australia in the early 60s, Lewis in 1961, as well as a separate researcher, Forbes, in 1961, isolated further viral specimens, and they wrote that for several years prior to July 1960, influenza and parainfluenza virus groups were the main causes of respiratory epidemic infections. But
Yeah. Okay.
in July of 1960, that pattern changed abruptly and mysteriously with a sudden increase in a number of infants admitted with bronchiolitis, bronchitis, and infants with pneumonia that was not paralleled by an increase in croup or a similar increase in pneumonia in older age groups. So the takeaway is that all of a sudden we're seeing a lot more infections in specifically something that affects the young, not just the young and the elderly.
Right.
And prior to this, July 1960, the diagnosis of bronchiolitis or inflammation of the bronchioles in the airways was pretty infrequent. And I couldn't find a satisfactory explanation because, as we said, it's not like this RSV had just suddenly sprung into existence, but prior to 1960, no one was really getting it. And this is not spreading out from this group of chimpanzees at Walter Reed. That just happened to be when the agent was discovered, but it had already been
Yes.
in the population. So I don't know. That was a fun little medical mystery I was unable to solve through research. Why things changed so abruptly in 1960, and this started becoming much more prevalent in the pediatric population.
Yeah, the most common reason for this, when we start seeing papers published and all this kind of a thing, is really just that we started looking, right? That we had an idea of what to look for, what to examine for, which symptoms, and then what virus to go for, etc. And that really helped us out, to actually see what we were seeing. I tried to do this too, and uh, you have to go back a little bit and use search words such as wheezing, and kind of describing the symptoms that don't include this entity of bronchiolitis per se. So, to actually see the descriptors, there are folks who talk about, oh, the rise of the industrial revolution, and, maybe we needed pollutants to be in the air, certain pollutants to go along with the viral infections themselves. We do know, Josh, that the more and more that we saw premature children who were born with immature lungs and who would have chronic lung disease of neonates because they were born premature, they needed respiratory support as babies, and then they were much, much more prone to their lungs closing up and shutting down. But yeah, you're right. We don't have a clean, clear explanation of all of a sudden, like, the literature just takes off, boom, at around that period of time. My bet, though, is on we recognized it. We knew what to look for the first time.
Maybe, but again, we see very clearly para-influenza and influenza, and all of a sudden there's this newer agent. So, yes,
Yeah.
we're recognizing it, which would explain a proportionate increase, but just not, I don't know. I'm not satisfied with that explanation.
Yeah.
Uh,
I get you. I get you. There are, new and emerging illnesses. Pertussis is actually, for instance, a fairly young thing. SARS-CoV-2, brand new, in 2019. But I don't think this is the case with this one, that it was a brand new disease. But yep, something was up.
yeah.
Something odd happened.
I want the origin story. Where is issue number one? But
Yes.
let's talk a little bit about RSV before we get back into the history. So it causes annual outbreaks of respiratory illness in all age groups. We're going to be focusing a lot on children, but it affects everyone. In most of the United States, it tends to start in the fall and peaks. Guess when? That's right, now, right now, in the winter, December, January, February. But the timing and severity of a season in a given community can vary from year to year.
Sure.
Now, part of the reason I wanted to talk about this as our next plague is that, of course, scientists are developing several vaccines. And just a few weeks ago, Pfizer announced that the FDA had agreed to review its RSV vaccine to be administered to adults over the age of 60 as a priority, and this could happen as soon as May. So, past the peak of this particular season, but it would still be a huge breakthrough as it would be the very first sanctioned vaccine for RSV, and it's shown positive results in a clinical trial for pregnant people, and that will be the next group they're seeking approval for.
Yes, this is going to be so cool. We can talk a little bit about the history of vaccines, etc. Coming up in just a little bit, why it took us so long to, create a proper vaccine against this. But it seems, especially for our babies, the best strategy is actually to vaccinate mom, okay? And then mom's immune system will react to the vaccine and it will, mom will form antibodies. And now baby, whether premature, mature, whatever it is, will be born with mom's antibodies on board and they will be protected. And this strategy, Josh, we know works really, really well for influenza. It works really, really well for pertussis. So we give moms Tdap when they're pregnant. And of course, now SARS-CoV-2 or COVID-19. We've got, now excellent data that you vaccinate mom, baby gets mom's antibodies, and this vaccine, which would be otherwise not terribly efficacious in a little baby because their immune system's not kind of mature enough to recognize it, this one, this is a great way to kind of sidestep their immature immune system. So I absolutely love the strategy. This is going to be great.
So we'll come back to the vaccine talk shortly, but let's talk a little bit more about the pathology and some of the symptoms.
Yes.
So as we said, it's a respiratory illness, usually a cold-like illness, but can cause lower respiratory infections like a bronchiolitis and pneumonia. uh, Now, again, although this is very common and it can be severe, I'll give you a few harder numbers. About 1 to 2% of children younger than 6 months of age with RSV may need to be hospitalized. 1 to
Yes.
2% doesn't sound like a lot, but there's a lot of kids out there,
Yeah.
and they're all, around each other.
Yeah.
Um, Severe disease is usually seen in very young infants, toddlers. Those who are considered high risk are the premature, those under 6 months, and then the usual suspects of chronic lung or heart disease, immunosuppressed, and people who have neuromuscular disorders, difficulty swallowing, clearing mucus secretions, things like cystic fibrosis.
Yes.
But fear not, parents. Most infants and young children infected with RSV do not need to be hospitalized.
Yeah, this is the best piece of news I think anybody can hear, because this virus really hit hard this particular year. It comes around every single year, by the way, but just to be a little bit reassured, if you don't have a very, very young child, if you don't have these kind of, these at risk conditions that Dr. Josh just mentioned, right? So, premature lungs, neuromuscular disease, in some cases, Josh, cystic fibrosis, or if they have congenital heart disease, where they get, cyanosis because their heart isn't, shaped the way that it should, frankly. And if you otherwise have, a kid, they're above 6 months of age, there's no asthma in the family, et cetera, then you're actually, by and large, the risk is pretty low for your kid to have to go to the hospital. Now, you might need to go see the doctor because they might need to get some support, some reassurance that, hey, they're going to be okay. Let me double check and make sure everything's all right. But that you don't have that super high risk of needing to go to the hospital and get oxygen and all this other kind of stuff, which can be scary.
Now, when you don't have some of these chronic conditions, although calling a condition chronic in somebody who's less than a year old is a little, it's
Yeah,
a semantic thing at
yeah,
best.
yeah, yeah.
Um,
Our
but
yeah,
but that's a pediatric thing. I'm a geriatric doctor, so
yeah, that's very true. Yes,
infants are most likely to be hospitalized with RSV when they're around 2.5 months of age because their lungs are still developing. They have smaller airways. Um,
yes,
Most of the time, when you see this RSV infection in kids, they'll have a runny nose and a decrease in appetite before any other symptoms appear. That'll be followed 1 to 3 days later by a cough, then sneezing, wheezing, fever may occur, decreased activity. Uh, Maybe the only signs of infection may be some increased irritability.
sure.
As compared to adults who get infected, usually have mild or no symptoms, more looking like a cold, an upper respiratory tract infection, which again, runny nose, sore throat, headache, fatigue. Uh, a full disease course in adults usually lasts less than 5 days. It's gone by the end of the work week. Although, just like in kids, adults may have more severe symptoms if they are over 65, have chronic lung and heart disease, or are immunosuppressed, and it can lead to an exacerbation or trigger asthma or COPD or AFib. So if you have other of these chronic conditions, an RSV infection itself may be completely unnoticeable, but it will set off your body's other chronic diseases.
Yeah, right. So, you start with something like asthma, all of a sudden you get hit with this, and it makes things worse. So that's the concern. That's the main concern. And, this is the same type of idea we think of with COVID. That we start with, okay, there's someone who's at risk for severe disease, then they get COVID, and this is when people get into weird conversations about, like, oh, did they die from COVID or did they die with COVID? These are kind of the things that we have to think about. But essentially, you have an interaction between two conditions going on that makes things much, much worse than either of the conditions alone or by themselves.
So let's circle back around now that we know what some of the symptoms of RSV look like. Uh,
Yeah,
I'll tell you very briefly just the pathology, the hardcore bio for all my med students out there. It's a member of the pneumovirus genus of the family Paramyxoviridae, which
sure.
is it's a negative sense RNA with an encapsulated genome and a lipid envelope. Most of
Sure.
our listening audience is not going to be super interested in that, but it's important and you'll learn why shortly.
Yeah.
That envelope is a plasma membrane lipid or fat bilayer that has three glycoproteins. This is the important part. Take notes.
Okay.
The F protein or fusion protein, that's what helps it attach, or that's what helps it merge with the cell. The attachment or G protein, and the small hydrophobic SH protein. RSVF, that fusion, is the main neutralizing antigen, highly conserved, meaning most versions of RSV have the same version of the F protein, and that's the one that's essential for the virus to be viable, to actually get in and do what it's trying to do.
Yeah.
The G protein is a protective antigen. That's what triggers your antibodies to attack it. Both of those antigens, F and G, are the candidates for vaccines and targets for monoclonal antibodies. Now, let's go back to the history. Bear with me, wake back up. Um,
So, well, just want to put it all together real quick. Okay. So you've got one protein which helps the virus do its thing to actually fuse together cells, fusion, F protein. And then the G protein is one of the most prominent antigens on the surface of the virus. This is what our antibody recognizes. All right. We're going to be talking about monoclonal antibody. Now, this is a form of immunization. We oftentimes call it passive vaccination because you're actually not showing the body an antigen. You're actually raising up the antibodies and giving the antibodies themselves as protection. So, if those terms come up, don't be afraid. But
So,
yes.
if we have known about RSV since the 1950s, why have we not developed some sort of vaccine before now? Well, interestingly, a word you never want to hear a doctor say.
Yeah. Yeah.
In 1966, there was a vaccine being developed, a formalin being similar to formaldehyde, like what we preserve our corpses in,
Yeah.
a formalin inactivated vaccine against RSV was administered to infants and children in 4 studies in the US. The immunized children were then exposed to RSV in the community, and children who were seronegative for the virus before getting vaccination, unfortunately and unexpectedly, experienced a pretty significant increase in their subsequent infections. They got more frequent infections, they got more severe infections, and sadly, a couple children died. And this pretty much ended all research into a RSV vaccine from the 60s until very, very recently.
Yeah, this has happened to us a couple of times, Josh. There was an era in vaccination where this was kind of the best technology available to us. We took the entire virus, the whole virus, okay, and we went ahead and we inactivated the thing. We shut it down using formalin. Formalin is it's a material, and we
I don't
think of
know
it
if
as
this is going to be the best analogy. It might be a little dated for some of our listeners, but think of it
okay.
like the dip in Who Framed Roger Rabbit.
It's a, that's actually pretty fair. I think that's okay. The well, the dip dissolved, kind of a thing. What formaldehyde and formalin does is it cross-links certain proteins, so it inactivates the virus by actually sticking its proteins together, right? Now, the the formalin doesn't come along into a person's veins, or anything when you inject it. You wash away the formalin, okay? And the idea is, well, you're presenting the body with the entire virus, so it should recognize it and it should be able to shut it down. But we don't fully understand why, but it happened with formalin fixed RSV. It did happen, Josh, with a formalin inactivated measles virus. But rather than provoking an immune response which shut down subsequent infections, it actually caused an unusual or an atypical immune reaction. And then the subsequent infections were actually a little bit severe, a little bit, hyper. So it didn't have the desired effect. And it's really important to tell people about this, not because, oh, scary vaccines. No, it's because when these kind of things are recognized, the biggest takeaway from this is we, meaning doctors and public health folks and everything, shut it down. It was very quickly recognized, and it was said, okay, no more. All right, we're not using this vaccine anymore. And that happened historically, and I'm very happy to say that the surveillance and everything about it worked really well, and we shut it down.
But of course, the scare from this, 2 children died as a result of receiving the vaccines in the studies, which meant everyone just said, all right, well, I guess we're just not going to be able to develop a vaccination for this. And this is, well, not long before the era of misinformation, but you can imagine how that would pay out now in the world of 2023. So, Now let's get into a little bit of this one. So, rather than continue trying to make a vaccine from inactivated virus, which led to a lot of highly technical explanations for why it caused this reaction that I will link to in the show notes, but it's a little heavy for this show. Um,
Yeah.
Researchers have been attempting to make a protein based vaccine. Remember F and G? I know you
Yep.
do, in which an isolated component of the virus, like a surface protein, is then used to trigger a protective immune response. So we break it off like a piece of that Kit Kat bar
Yeah.
rather than using the whole thing. And a major breakthrough came when scientists like McClellan characterized the different conformations of protein F. So, protein F exists in two different forms: a post fusion form that's very, very stable,
Hmm.
and a pre fusion form that is not. The protein that we're trying to use to make a vaccine takes on the pre fusion form when it's still unstable and would have more trouble attaching. So, when the virus and host cell are coming together, the protein based vaccine would, for lack of a better word, cockblock them.
Yeah. There are better words, but I like it.
There may be better words, but
Yeah.
I think that is the most accurate descriptive one.
Sure.
And it will then transition to a second form once the infection's taken hold. So prefusion F is a very unstable protein, but that's what's fully active and therefore gives you the most robust immune response. So that was what was needed to make an effective vaccine. And that is what is essentially being tested.
Yes. Correct.
So very exciting. So the new vaccine that is waiting FDA approval could be available as early as spring of 2023 is worlds apart from this 1966 formalin vaccine. It's using a different method, a different particle, different understanding. So that's just all historical context. Uh,
Yeah.
please be aware. Um,
Yes.
Now, in one trial, Pfizer gave the vaccine to pregnant people to boost their total antibody numbers. As we said, the idea being that those antibodies would then get transferred to their infants. And in their press release, they said that this strategy had an efficacy of 81%, 81.8% against severe cases of RSV in the infants in the 90-day postpartum period. So, right after being born, that first month and a half, 81% of the severe cases, the ones that could put you back in the hospital or keep you there, were protected against.
Wow. That's really beautiful.
On the other end, my end of things, in another phase 3 trial, it was reported to have an efficacy of 85.7% at preventing severe disease in adults over the age of 60. One other treatment we have, the monoclonal antibody palivizumab.
uh, Palivizumab.
So this monoclonal antibody can be administered monthly as a prophylactic to reduce the severity of illness in infants and young children. But as I'm sure you can imagine, the cost of a monoclonal antibody, the need to get a shot every month in a young child, and
Yes.
so the frequency and the fact that it must be injected usually means not the first line of treatment, and physicians will only give it to very high risk infants and children.
Yes. So, A, because of how much we have, so it is important to note that this is kind of a precious resource. We can't just give it around willy nilly. We do have to find who is at highest risk and administer it to those kids. And it has a short half life to it, right? Antibodies, just in and of themselves, don't last very, very long. So you do have to then administer it, in this case, once monthly during the actual time of the yearly epidemic. And Josh, this is can be really, really frustrating. So what I have to do actually is I have to watch how uh, the disease is spreading by looking at epidemiology. And if you'll remember back, some of you wonderful people who've been following with us for a while, in influenza, we use our wonderful sentinel chickens, right? So
Oh, I love our sentinel chickens.
yeah, yeah. So there are some cases where we use that. There are some where we have tracking across the nation using the National Respiratory and Enteric Viral Surveillance System, NREVSS. And I have to follow it and see when in our region everything is starting to peak. And in order to conserve this resource properly, I have to kind of turn it on. I have to say, okay, now it's time to start administering this. So now please begin. Okay. And then, in our neonatal intensive care unit, when kids are getting kids start discharging, and then our outpatient clinic, they have to call and they have to get this medication, reserve the doses and then start giving it out. It is not an easy process. We do have an antibody on the horizon, Josh, that has a much longer half life that can be given once per RSV season. So we're excited for that to complete phase 3 trials and come out. But for right now, with palivizumab, we're kind of stuck.
Let's talk a little bit about the tripledemic and
Oh, yeah.
comparing RSV to COVID to flu. Which is
Yeah.
which? How do you know? Does it even matter? Uh,
And we do have to keep in mind that we talk about the triple demic because the viruses that we're going to mention are easily the most prominent kind of on our in our scope. But the truth of the matter is, it's much more than a triple demic. When respiratory viral season comes around, there are perhaps hundreds of different viruses that are circulating alternately throughout the season.
a Google demic.
Yeah,
A
exactly.
Bing demic? Nah.
No,
Um,
sorry.
so, but they do tend to be grouped into families. So, as as was mentioned in our cold open song, at least a
Yes.
little bit of it, flu symptoms tend to start all of a sudden. They come on almost immediately, while COVID and RSV tend to come on more gradually. All three will cause similar symptoms, but looking at the timing can help clue you in. Certain
Sure.
symptoms tend to dominate with one illness over another. So, fever, for example, much more common with flu and then COVID than RSV, and the
Hmm.
CDC publishes weekly flu and COVID maps, just like Google, that can help you figure out if one virus is more active in your community, as well as reports on local RSV activity. So here's a quick primer. For
Hmm.
COVID, symptoms start gradually, tend to get worse around day 2 or 3, and sore throat tends to be one of the earliest symptoms, especially at first. Is that the incubation period is 3 to 10 days, usually 4 to 6, and it is contagious from the onset of symptoms until the fever is gone and at least 10 days have passed.
Yes. And we are using some, kind of statistical data to determine this. This isn't one of these things where, we know for absolute sure this is when the shutdown is. However, Josh, we actually have done in adults not only prospective studies when people actually natively come down with this viral infection, but we have done what's called volunteer studies where people have, their health are checked out and everything, and then not with influenza because that one's scary, but with a healthy adult, put RSV up their nose, watch and see how they do, and then actually in a controlled environment see how long it takes for them to stop shedding the virus when, swabbing daily or something like that. So they're small studies and stuff, but they're very, very efficacious to help us find this stuff out. And I absolutely love
Those are the real heroes. People who
it.
volunteer to let scientists pick their nose daily.
It's true.
Um,
Volunteer respiratory viral studies, as was done in Salisbury, England, at the Common Cold Research Center, I believe it was called.
yeah, Cold
And
Camp.
yeah, yeah, exactly. And others such as that, they've really given us beautiful data on the dynamics of these viruses. And then, we can go on and extrapolate from that and be able to give these type of guidelines for
So,
viruses.
so as we said, COVID, 3 to 10 day incubation, usually around 4 to 6. Symptoms start gradually, get worse around day 2 or 3. For flu, the incubation period is shorter, only 1 to 4 days, 2 on average. It is contagious 1 day before the symptoms start and up to 7 to 10 days after symptoms, including fever, begin. The
Yes.
worst days are 3 to 5. That's what I like to call my sexy radio voice day.
Yeah, yeah, yeah. Or if you happen to catch this, I think during, because it can happen in the summertime. If you happen to catch it during your con time, your
Oh,
comic con,
con crud, yeah.
this could be a part of your con crud when you start feeling it like this.
And
Yes.
symptoms tend to stay the same for about 1 to 5 days before slowly fading and
Yes.
getting a little bit better.
And by the way, it can also modulate during that time, meaning that it goes from having a nose that's pouring out, runny, 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 changing over to a more, congested or blocked up kind of a thing. Or your snot can go from clear to green back to clear, which is a really common thing. Or it can go from throat to nose, then down to like a tickle, like a cough. So
But
don't
but
don't
with
be concerned if it.
flu, you
Yeah, yeah.
tend to see much more, again, fever, very common in flu, especially in the elderly,
Hmm.
along with body aches, myalgias. Uh, you don't really tend to see muscle aches as much in COVID or RSV. COVID tends to have more diarrhea or gastric upset. RSV we'll talk about in a moment. Flu really hits you in the body as well as the lower respiratory tract.
Yeah, it's a big hallmark of, I'm coming down with something, I'm coming down with the flu. And it really turns into a flu-like illness if you haven't diagnosed it. If people say that, oh, not only am I high fever, but that achy, crampy kind of feeling all over where your arms and legs feel heavy. That's a big hallmark of flu.
Now, RSV, the incubation period again is about 2 days, and it is contagious again about 7 to 10 days after symptoms, which are tend to be at the worst on day 5, so about halfway through, and then people start to gradually feel better. People with RSV get a huge surge in mucus production, which is why most of the RSV symptoms are related to runny nose and congestion.
Yep. Snot, snot, snot.
Even if you have RSV, most people don't usually test for it because there's no treatment yet. We are talking about the vaccines, we're talking about those monoclonal antibodies, but there are generally no accepted treatments other than supportive care. And even in the severe cases, it's supportive care in a hospital.
Yeah.
Now,
There,
there
there there's no specific antiviral out there
now if you're
that works well.
super interested in testing, there is an at-home test by LabCorp that can test for all three, COVID, RSV, and the flu with just one nasal swab. And while you
Yep.
can do this test at home, you still have to drop off your sample at a local lab and wait for results, which take 1 to 2 days to come back. Could be up to 3 or 4 if it's over a weekend. And by that point, most of this will already be resolved. So it's really just done out of academic interest.
Yeah, there are labs that do collect samples a little bit more aggressively or more commonly, and a lot of those, Josh, are actually surveillance labs that are in the public health network. So it feeds back eventually up to the CDC and the large surveillance systems to help us keep track. Now, as molecular tests, antigen tests are becoming easier, cheaper, all this kind of a thing, I personally would love to see the availability of at home testing and for that to be submitted as active surveillance, because more data is always helpful to see the dynamics of these epidemics. But that's just my nerdy public health self.
So we'll throw up a handy dandy chart of the differences between, but all of these symptoms can be seen with all three. It's just each one has its own fashion sense and style, as it
Yeah,
were.
yeah, exactly. Now, there is overlap, and there's enough overlap that you can't be sure, if you have these symptoms versus these symptoms. These are really just percentages. Flu much more common, to cause fever and body aches, etc. But for us, when we're sitting there as doctors, we can use these as predictors, and I think much more importantly, Josh, we can use it to do things like, okay, hey, if we maybe don't have as much availability for flu testing, this person over here who has body aches and fever as well as their respiratory symptoms, it's probably going to be a better idea to test that person for flu versus this person not, because of course for influenza we do have antivirals that work semi okay to help you get better faster.
Yeah. So that's it for this week. I hope that that was enticing and infectious enough that you come back and continue to visit with us through the rest of the year. We do have, of course, journal clubs as well as some more guest episodes coming up, including one where we will talk some sports medicine. Because I have not been living under a rock and did notice that we've had a perfect opportunity coming up in the future. For now, however, let's leave off with a just the tip again from Bangalore.
Yeah. So in beautiful Bangalore, India, if you go close to the center of the city, actually, Josh, where the what we call the old city, you can find Bangalore Medical College and Research Institute, the big campus that's there. There is what they call the undergraduate and graduate campuses. So in India, as with many other countries around the world, including the UK, medical students are actually by and large chosen from their 12th grade. So what they call pre-university college is, 10th, 11th and 12th grade. So that actually they'll be testing and going into medical school a 6-year program, boom, straight from when they're 18, which is scary if I kind of think about it. So that undergraduate campus is where you earn your MBBS, which is called the Masters in Biology Bachelor of Science. And that's the undergraduate medical degree. And that campus, Josh, absolutely beautiful. They've got a brand new building for all of the undergraduates that was put up in 2018 with beautiful new lecture halls. But I think the hallmark for me, and I'll definitely send you some pictures that I was fully allowed to take, given permission by one of the assistant professors there who took me around. Is two museums. They've got a museum of anatomy and a museum of physiology and pharmacology that have kind of beautiful specimens that you can view, sitting there in formalin and formaldehyde preserved, so you can see, and some of it you should be careful, you should be braced for it, because they are malformations in, embryology, so like how a baby is formed, and then cancer in a bone or something like that. And then, Josh, the most fascinating for me is not too long ago, these medical students, because they're starting from age 18 and they have to learn basic anatomy and physiology and all these kind of things, biochemistry, they would do studies on live animals. And so there are, Josh, dissection tables in there for all of these animals, and then instruments that you would use to test things like muscle strength and nerve stimulation and cardiac function and all these kind of things, that if you go back and you see in textbooks, we don't use it anymore, where you would record like the impulses from a muscle, on that cylindrical drum, as that needle would kind of go up and down, like a little, EMG, like that. So absolutely such a cool display, not only of anatomical specimens and teaching physiology and all these kind of things, but also a beautiful history of medical education in and of itself, showing how med students used to learn and contrasting it with the methods that are used today to teach them the same concepts without resorting to things like, the degree of vivisection and animal testing that we have in the past.
Methods
So
like TikTok and the Travel Medicine Podcast.
yeah,
So,
it was so
so
absolutely beautiful, and I would like to thank Dr. Prashant, who is an assistant professor in physiology, who not only got his MBBS but his MD, so his postgraduate medical degree, and is an excellent professor and showed me around. So shout out to you, Prashant, and thank you so much.
So that's it for this week. As always, we love to hear your comments, questions, and feedback. If you'd like to support us spiritually, emotionally, or financially, links to do that are in the show notes, along with a chance to subscribe to our bonus tier that has things like songs and conversations that go nowhere, extra material that we put up. The show is produced by me with a lot of help from Dr. Santhosh and friends. Our theme music is composed by Rachel Leisure. And until next time, as always, start the new year with a song in your heart, soap on your hands, and a shot in the arm. And once you've done all of those things,
Yeah.
find a country that looks interesting, get out there on a plane, hopefully not Southwest, and happy travels.
Bye, everybody.